Hi, good evening, everyone. I'm Elizabeth, a genetic counselor at the Perlmutter Cancer Center at NYU Langone Health.
Hi, I'm Dr. Sigireddi. I'm one of the clinical and cancer geneticists and our director here at the high-risk cancer genetics program.
And hopefully you can see our slides okay. And we'll go ahead and get started. So today we will be presenting on hereditary cancer and genetic testing. So this is our team. We've got a few different pictures, a few different team members, but overall we have 11 certified genetic counselors, 5 genetic counseling assistants, a manager, Dr. Sigireddi, our director, and other geneticists and doctors that assist our practice, Dr. John Pappas and Dr. Yael Simons. And as a team, we offer genetic counseling, testing, risk assessment, and management recommendations for people with hereditary cancer predisposition. We are housed in Manhattan, but we do see people across all the sites. So Brooklyn, Long Island, we're able to accommodate all those sites. So to start off with, I'm just going to go through some basic information about the origins of cancer. So most cancer is not due to hereditary factors. Only about 10% of cancer is due to hereditary factors. The majority of it is going to be due to normal aging, diet or lifestyle factors, or exposures that we have in our environment. That makes up about 70% of what we call sporadic cancer. The other portion that's sort of undescribed is called familial cancer. And that basically means that we may see clustering of cancer in a family, maybe at older ages, and it's not something that we can pinpoint an exact hereditary predisposition for on a genetic test. There are some signs that we look for when we meet with people and discuss their personal or family histories of cancer that may alert us to suspicion for an inherited predisposition. So one example is if someone or their family member is diagnosed with cancer at young ages. And for cancer, we typically think of a young age of diagnosis as being 50 years old and under. If a person has had multiple primary cancers or bilateral cancer in an organ where that makes sense, so like bilateral breast cancer, both breasts, or bilateral kidney cancer, both kidneys. Having multiple family members on the same side of the family affected with the same, similar, or related types of cancers. Seeing cancer in multiple generations of the family, so like grandparents, parents, children, et cetera, and rare cancers. Some examples of rare cancers are ovarian cancer and male breast cancer. And another one that is not there, I'll add in, is certain ancestral backgrounds. So for example, people who are of Ashkenazi Jewish descent can have a higher frequency of certain hereditary predispositions. So in general, we have many genes that are all involved in the functions of our body, in our normal growth and development. And there's only a small subset of these genes that are typically working to protect our body from developing cancer. And these cancer protection genes are the ones that we focus on in the genetic testing that we do. So our genes are composed of a string of letters. So you can think of it like a genetic code or a DNA sequence. Some people like to think of it as sentences within a book. And the genetic testing is essentially a spell check of these genes letter by letter. And the laboratory knows what code or what sequence they expect to see. And if we see something that's different than what's expected, that may be a genetic mutation, causing that cancer protection gene to not work properly. These are some examples of some of the more common hereditary cancer susceptibility genes that you may or may not have heard of. So BRCA or BRCA1 and 2, PALB2, MLH1, MSH2, and we all have 2 copies of all of these genes. We inherit one from our mom and one from our dad. Like I mentioned, these are good genes. They're there to help us, prevent cancer within our bodies. So we want them working. If there's a mutation in one of these genes, then we know that we are put at a higher than average chance for certain cancers across our lifetime. So this is sort of what I was alluding to before, that the genetic test is sort of like a spell check of each gene sentence. So as you can see in this example, the letter C that sort of has the sparks or lines around it has been changed. In the sentence above, that letter is actually a T, so it's changed T to C. And this is more or less what the laboratory is looking for when they look at someone's genetic code. And a harmful change in that sentence, something that causes that gene to not work properly any longer, is what we call a gene mutation. The inheritance pattern for most hereditary cancer genes is autosomal dominant, meaning that it's passed down 50-50. So if, let's say, the father in this scenario has a hereditary cancer gene mutation, there's a 50% chance for each of his children to inherit it, 50% chance for them to not inherit it. So in this scenario, one son and one daughter did inherit it, and the other son and other daughter did not inherit it. Something that we like to point out to our patients, just to think about when we're doing genetic testing in a family, is that it is typically best to do genetic testing for a person in the family who has had the cancer diagnosis or has had the diagnosis that's the most suspicious for hereditary predisposition. So like the youngest age, or maybe a rare cancer, or something along those lines. That's because, like I mentioned earlier, hereditary cancer is not the most common cause of cancer. We only identify it about 10% of the time. So by testing the person who has had the cancer diagnosis, if we find a mutation, that likely explains their cancer diagnosis. And then we can sort of branch out to the other family members and let them know if they have the same risk or not. We do see people who come into us for a family history of cancer and they've never had cancer themselves. And that's fine. We can still do testing for that person. But just understanding that there can be limitations to that testing, because we could get a completely negative or normal result, but there may still be something going on in the family that we just don't know about because we haven't tested the right person yet. Most of the genetic testing that we do nowadays is through multi-gene panel testing, meaning that we look at many genes at one time that are associated with multiple different types of cancers. And the genes that we test for can have ranging levels of risk. So the genes I've mentioned before, like BRCA1 and BRCA2, these are considered high-risk genes, meaning that they greatly increase someone's risk for cancer over the general population. But some of the genes that we test can be moderate risk genes, or genes that just have a slight or a low increase in risk. And those, as compared to the general population. And our management recommendations typically follow suit with not only the type of cancer risk that somebody has, but also the level of risk. So we are going to make more changes to somebody's medical management with a high risk gene compared to a gene that maybe just has a slight increase in risk over what the average person's risk is. And our information about the genes and the cancer risks are always evolving over time as science evolves and as we learn more. So there are inherently 3 different types of results that can come back when we look at any gene. We have spent most of our time talking about a positive result, meaning that a gene mutation is found. Of course, the flip side of that is to see a completely negative or normal result, meaning everything looks like it's functioning normally. But there is a third type of result called a variant of uncertain significance, meaning a variation is found, but the lab doesn't necessarily understand what it means at this point in time. They don't know if it changes the genetic code enough in order to cause that cancer protection gene to stop working properly, or if it's just a part of normal human variation and is nothing to worry about. So this is an example of a sentence that might sort of describe a variant of uncertain significance further. So imagine the scenario where the laboratory is looking for the sentence, "The cat ate the rat." In somebody who has a negative or normal result, we'll see the sentence, "The cat ate the rat," just as expected. In somebody who has a mutation or a positive result, we would see "The car ate the rat." And as you can see, that completely changes the meaning of the sentence. An uncertain result might be more like "The cat ate one rat." We're not really sure if that changes the meaning of the sentence or if that's just another way to say that sentence and isn't harmful. Variants of uncertain significance are extremely common. We see them every single day, multiple times a day. We treat them as though they are negative or normal until more information becomes available. As science evolves, as we test more people and learn more. So we do not typically recommend making any changes to care based on uncertain results or testing multiple family members for uncertain results specifically. But as time goes on, as we learn more, we've found that over 80% of these uncertain variations are just normal human variations that we just need a little longer to understand. So we don't typically do anything with them, and we'll sort of more so look back to the family history of cancers to make recommendations for someone's risk or management instead. The last thing that I share with everybody is about genetic information protection laws. So GINA, the Genetic Information Non-Discrimination Act, protects you from genetic discrimination from your health insurance company and an employer. So for example, your health insurance company would not be able to charge you more or deny you a health insurance plan or policy because of a certain genetic test result. This law does not protect from discrimination from supplemental insurances like life insurance, long, short-term care, or disability insurance. What that might mean is, let's say you go to take out a life insurance policy, they can ask you if you've had genetic testing, just like they may ask you about other medical history factors and can choose to charge you more or deny you based on that information. So something to keep in mind before undergoing genetic testing, perhaps.
So where I come in to play a role is after someone has had genetic testing. Oftentimes, if someone is interested in genetic testing, they'll meet with one of our genetic counselors like Liz, kind of go through all of this process. And if it is determined that you might benefit from this kind of testing, and you ultimately wind up having a positive result on your genetic testing, or risk models indicate that you might be at a higher risk for certain kinds of cancer, such as breast cancer, higher than the general population in the face of a negative result, you would come to see somebody like myself or Dr. Simons at our practice. And basically what we do is we go specific to the mutation you have or specific to your increased risk and sort of walk you through what that process looks like long term. What kind of screening do you need? How can you best reduce your personal risk of getting cancer? Like Liz said, most cancers are not hereditary, but of those, that 10% that she had mentioned, it's not always going to be the case that someone who tests positive does have cancer. It just means that you're at an increased risk of developing cancer. As we've learned more over time and tested more people over time, the more data that we have, the better risks that we can sort of estimate someone at for having different kinds of cancer. So my gut feeling right now, and science has shown us this, is that the more people we test, the lower those percentages will be over time. But right now we're sort of operating with what information we have. And so some of these risks that we quote people at might be a little bit higher than are true to what's actually happening. But without testing everyone in the world, there's no way for us to know yet. So we operate with the best information that we have right now, and sort of provide people different ways to prevent cancer and early detection of cancer. So a lot of that winds up being screening, but there's some other things we can do to mitigate people's risk of developing cancer if they have a predisposition to cancer. And so most of the common syndromes we see are related to those genes that Liz had mentioned earlier. And so the BRCA genes typically will cause things like breast and ovarian cancer. There's a couple more rare cancers that are associated with those genes that I'll go over. But we also see different genes associated with colorectal cancer. Those were the genes starting with the letters M that she had gone over. And then other genes associated with prostate cancer and pancreatic cancer, some of which are related to the aforementioned conditions that I mentioned. What do we do in terms of screening someone for different cancers? So I'll walk you through a couple of examples, but this would really just mean that if somebody has no personal history of cancer and has one of these mutations, we start them on a screening protocol where every year they get certain types of screening. So let's say if you have something that predisposes you to breast cancer, we'll start you on mammograms if you're not already doing so, and integrate something else like an MRI of the breast to give us a little bit more information, make sure you're kind of covered throughout the year with some sort of screening. There are other things we can do specifically for breast cancer as well, which would be using medications that can help lower your risk. We call this chemo prevention. It has nothing to do with chemotherapy in terms of treatment, but it uses some of those chemotherapy agents to prevent cancer from developing. And so usually what that entails is lowering hormone exposure to the body and preventing you from potentially developing an early onset breast cancer if you're predisposed to such things. We also offer things like preventative surgery. So I wouldn't be the one to do the surgeries, but I would help you sort of get a sense of what that looks like and who best to speak to in terms of having a surgery to remove any organs that are at incredibly high risk of developing cancer. And we have recommendations depending on what gene is affected. And if you are a candidate for something like that, we would definitely go over what that looks like, when you would need to have it, do you need to have it? And the answer is sort of, it depends on personal preference and past medical history, and no one's going to ever make you do anything that you don't want to do, but just giving you all those options. So this sort of includes some of the information Liz had mentioned before, but again, generally 10% or so of all cancers are hereditary. And we'll talk a little bit about hereditary breast cancer because that's probably the most common thing that we see in our practice. And like Liz had mentioned, the BRCA1 and 2 genes make up the bulk of hereditary breast cancer. And these are probably ones that you may have heard of if you're at all sort of familiar with the cancer genetics world, or if you know Angelina Jolie. She had done a little bit of like a public service announcement for us probably about 10 plus years now. And her family had a history of BRCA mutation in it, and she underwent a preventative surgery, like I was mentioning, where she had both breasts removed way earlier than she possibly would have developed cancer, just to kind of take that risk off the table. And so that's a kind of thing that we would discuss in these types of visits. So kind of walking through BRCA as an example, again, if you test positive in one of these genes, we sort of stratify your risk depending on what your gender is, what your organs that are highest at risk are. So if you're biologically a female, we would discuss the risk of cancer developing in your breasts and your ovaries, what that looks like in terms of the specific mutation you have. So if it's BRCA1 versus BRCA2, there's a little bit of a difference there. But overall recommendations remain fairly similar. And so we kind of walk you through if you have a breast cancer gene, we would want you to have breast imaging earlier, like mammograms or MRIs. In terms of ovarian cancer risk, we would want to implement some sort of screening protocol, such as an ultrasound of the ovaries, a blood test that kind of gives us a sense whether or not there might be something brewing in the ovary that we would want to catch a little bit earlier. Similar things for men. Men are still at increased risk for breast cancer if they carry one of these genes, but we would also sort of start them on a breast cancer screening protocol that they might not otherwise be on if they didn't have this mutation. And again, more rare cancers like pancreatic and melanomas. And we kind of point you into the right direction. We have a screening protocol at our facility for people to have pancreatic cancer screening outside of this if they have a family risk, but also with genetic mutation predisposition. And so this is sort of what I just went over in terms of breast MRIs, breast exams, things like that, that would be dictated by your genetic mutation. And then in regards to the ovaries would be one of those organs that are also at very high risk in this specific genetic population. And we would recommend people consider having those surgically removed, as well as the breasts, to sort of prevent that cancer from developing. Another example of something that we see fairly common is hereditary colon cancer. Again, that 10% or so are gene related of colon cancers. And the ones that we'll see the bulk of are things called Lynch syndrome genes. And so there are 6 different genes that are implicated in Lynch syndrome. And Liz had mentioned a couple of them, but we'll just kind of go over what that looks like if you were to have Lynch syndrome. So Lynch syndrome is a little bit more complicated than the BRCA genes. There's a bunch of different kinds of cancer, primarily colon cancer and endometrial cancer are the ones that we're really thinking about having an association with Lynch syndrome. But if you were to test positive in one of these Lynch syndrome genes, which are all listed out on the top of the table, we need you to sort of think about getting screened for all of these different kinds of cancers that are listed on the left-hand side. A lot of these can be done with colonoscopy and upper endoscopy, which is kind of like a colonoscopy, but they go through your mouth and the camera kind of goes down and meets the area where the colonoscopy camera sort of kind of ends. And so we try to get the whole GI tract screened in people who have Lynch syndrome, but there are also other organs as well. Again, ovaries are also playing a role here too. So we talk about what that kind of screening protocol looks like. Again, this is pretty much what I just said. Oops, sorry, went too far. So in terms of ways to mitigate your cancer risk, outside of the screening that I mentioned and those other things like chemo prevention, so taking medications to help reduce your risk or having organs taken out preventatively, there are other ways to just sort of overall reduce your risk of cancer. And I think that you may have gone to talk about nutrition and cancer risk, but one of those things is to definitely eat a healthy diet, increase physical activity. Being overweight can definitely predispose you to certain kinds of cancer. And also smoking. Smoking is probably one of our biggest risk factors for various types of cancer, even ones that are not related to the lungs. I would also always advise people to attend their regular preventative healthcare checkups. Nowadays, we're recommending people undergo routine cancer screening on top of things like mammography, but having colonoscopies done depending on your family history, starting as early as age 45. So getting some of those routine things out of the way would definitely sort of get you to the best state in terms of preventing your overall risk of developing cancer and catching things a lot earlier than we would have if not. So that's kind of our talk. Please let us know what kind of questions you have and what we can do to better help you understand what genetic risk looks like in terms of cancer and the best ways that you can kind of optimize your health.
Let's see. All right, I have a question. How reliable are sites like 23andMe and Guiding Care? Is that something that you see a lot in your practice with patients coming in?
Yep. I mean, you can take this one.
So 23andMe, from a clinical genetic testing standpoint, tests for very little compared to what we can offer. It tests for the 3 common mutations for the Ashkenazi Jewish population in BRCA1 and 2, and 1 mutation in a common, European population colon cancer gene. So it's going to be really limited for most people. Beyond that, it's not going to give you much, clinical genetic testing information. Did you want to add to that?
Yeah, so it will tell you some kind of fun things. They'll have like what we call SNPs, or these little genetic changes that are not necessarily like a genetic mutation that makes you at risk for any sort of disease, but little variation that might be unique to you versus the general population. For example, there's one gene where a little tiny variation in one person might cause them to feel like cilantro would taste like soap versus the general population that doesn't feel like that. So those are the kind of quirky things that 23andMe is kind of fun to see, those kinds of things that they list out. There are a couple of other things that may have implications in terms of long-term health that are not related to cancer. So neurogenetic things, sometimes they have listed out like Alzheimer's predisposition genes and things like that. It's kind of hard to say because a lot of these are not necessarily things that will actually confer a risk of developing something like Alzheimer's. It just tells you whether or not you might be at an increased risk. And so it becomes a little tricky to suss out whether or not this is actually something that will have an implication on your overall health, and sometimes leads to more questions. So if you're somebody who feels very overwhelmed by a lot of information like that, it might be better to talk to either a genetics person or a primary care doctor and kind of get a sense for what you would be looking to get out of that outside of some of those more fun things before you get tested.
Great. All right, we have another question. Reads, I had the panel of 30 cancer screening at NYU 5 years ago. Are there more gene mutations to be tested since then? And is it recommended to have further genetic testing after 5 years?
Yeah, so we've definitely have developed way more of a technological advancement in terms of what's on the panels, how some of these tests are run. Depending on what your personal history is, that sort of helps us guide whether or not you would benefit from additional testing. So let's say somebody in your family tested or has some sort of cancer and you're trying to get a sense of whether or not you're at increased risk. If that person tests negative and you test negative, you might not stand to benefit too much from that. But if you're somebody who has a cancer history and tested negative with a limited panel, you might benefit from advanced screening.
Yeah, and I think 5 years is a good check-in point to check in about new genes and new technologies. That's what we tell most people, I think, to check in. It also might depend, like you said, on the specific types of cancers. So for some types of cancers, we were testing basically the same genes 5 years ago. For some types of cancers, we've got a whole new set of genes to test. So I think it's not a bad idea to check in. It's not unreasonable.
Our next question is, I have a CDKN2A and melanoma 3 times in the last 25 months. I found it hard to find a doctor who has experience with this. Any recommendations?
Definitely. If you're interested in just sort of talking a little bit more about this, I'm happy to meet with you. If you're looking for a dermatologist, we do have several providers here at NYU who we refer people to, and particularly one, Dr. Liebman, who has an increased sort of interest in cancer genetics. So if that's what you're looking for, we'll be happy to put that contact information in the chat, but you can also reach out to me.